Good, good afternoon, good morning. Thank you for coming this sunny Sunday morning here. So the last block of this session before the interactive part is the colitis. To avoid a repetition of the content with previous speaker, the organization asked me to include a differential diagnosis of IBD colitis with other causes of colitis. So initially we will discuss the different causes of colitis and how we can differentiate. As you know, as a matter of a brief introduction, there are different benefits to include cross-sectional imaging for assessing. In the workup of colitis, it's wide available, it's less invasive than colonoscopy, that is considered the gold standard, and allows evaluation of the bowel wall together with the perienteric changes that sometimes can offer relevant information, and also for assessing complications that not always can be assessed by endoscopy. This is just what was said in the previous lecture. The criteria of the colitis are very similar to the criteria of enteritis in the terminal ileum, while thickening over 3 millimeters, the most used cutoff on ultrasound, increase signal Doppler registration, and brightness, increased brightness of the perienteric fat on ultrasound can be used as a criteria of colitis. On CT and MR, the criteria are quite similar. Again, wall thickness and increased enhancement, and also sometimes we can see some fat stranding and even some variable quantity of free fluid surrounding the segments of the colon with activity. But the main problem occurs when we saw some situation like this. What's this? It's a colitis, but what kind of colitis? This is the key point. If there is no previous diagnosis, this could be a bit challenging, because imaging alone is usually not enough for establishing the etiological diagnosis, and we need more information. It could be inflammatory, it could be ischemic, it could be infectious, we don't know. We need more data. And there are patients that are not only images, so usually the final diagnosis is established together with the clinical, imaging, biomarkers, culture in case of infections. So, and let's briefly review the infectious colitis, and just it can, because it may have an overlap of with inflammatory bowel disease on the colon. As I told you, the usually can be confirmed or established with the clinical course, usually more acute, in the stool or blood culture, and even in some atypical cases of colitis with the colonoscopy and obtaining biopsies. The classical distribution of some certain etiological causes of infectious colitis in clinical practice is a bit useless, because there is an overlap of different entities. So for establishing the final antibiotic treatment, we require to detect the etiological germ, and maybe it could be helpful in some particular cases in tuberculosis or in patients with risky sexual activities that had a proctocolitis, proctosigmoiditis. Maybe you can suggest some venereal etiology, or in immunocompromised patients with diffuse colitis, maybe we can suggest the presence of a virus. Just few comments on the tuberculosis, because it's the big mimicker of other entities. For example, the main diagnostic, the differential diagnostics can be established with Crohn's disease, and also sometimes with colon cancer, because it has a trend to, especially in chronic phases, to generate the strictures of the colon. So, but the main characteristical feature are the large, hypointense or hypodense lymph nodes, regional lymph nodes, big in size, and in the acute phase, with low attenuation in the center, and in the chronic phase, they have a trend to calcify. Also, we can see ulcerations that may mimic the Crohn's, and as I told you, in the chronic phase, some strictures that may be a bit difficult. Tuberculosis also is challenging for pathologists, even after the bowel resection, for differentiating between Crohn's and tuberculosis. But this is a very particular clinical scenario in patients with previous pulmonary tuberculosis or with immunocompromised immune system. And in this particular setting, immunosuppressed population, this is key for differentiating IBD with other infection etiologies. And just a few comments on this specific clinical scenario. And maybe the paradigm model of the immunosuppressed patient is the patient that underwent a bone marrow transplantation. Initially, they have zero differences and are usually under a broad spectrum of antibiotics. So this combination is critical and is very dangerous for developing the neutropenic colitis, usually typically in the right side colon, and with marked inflammatory changes. So the correct clinical context is key for establishing the diagnosis. In that subgroup of patients and other patients under broad-spectrum antibiotics, for example, patients in the ICU units, it's not rare to find the pseudomembranous colitis, and in that point, in this particular case, imaging may be key for establishing the diagnosis. Classically, diagnosis is established with the detection of the toxin, but can be negative in up to 40% of cases. So the identification of the accordion sign may be very helpful for the clinicians in the workup of this etiologic diagnosis. Later, after the first month of the bone marrow transplantation, these patients are susceptible to suffer from infections. The most common is the cytomegalovirus that may have a diffuse infection of the colon. And the final diagnosis is done after obtaining biopsies of the mucosal. But in the meantime, we can suggest this possibility, and the patient can be covered with the correct treatment. Other causes are the herpes virus, adenovirus, rotavirus, and even fungus. And lastly, this patient may have the acute phase of the graft versus host disease, but hardly ever represents a challenging problem for differentiating IBD because it's very specific of this subgroup of population. Another entity that sometimes may generate some confusion is the ischemic colitis, but again, the clinical scenario is key. Usually, the ischemic colitis may occur in the elderly population in a situation of hypoperfusion, usually transient hypoperfusion, and this is not a real arterial occlusion. This hypoperfusion may generate an initial phase of colonic ischemia, but can be recovered after the restoration of the perfusion. And then that we have is the consequence of the transient ischemia with reperfusion and infection, because the most sensitive part of the ischemia of the bowel is the mucosa. So there is a disruption in the mucosal, and easily the bacteria in the colon may over-infect the colon. So the most common situation that we can see is that a specific colitis in some elderly population. Again, in this clinical scenario, the main differential diagnosis is ischemic versus infectious rather than IBD. Another findings based on imaging that may be helpful is the detection of the classical points. The most sensitive points are called the watershed distribution, usually affects the most distal part of the transverse colon, the splenic flexure, and the most proximal part of the descending, and the rectosigmoid junction. Also, ischemic colitis may have a vascular distribution, and not infrequently we can see the left colon involved without continuous. And lastly, we have the inflammatory bowel disease, that is the topic today. The diagnosis is established with a combination of the clinical suspicion, endoscopy data, radiology, and histology that supports the clinical suspicion of IBD. What is the role of cross-sectional imaging at the time of diagnosis? We can suggest if we can find some specific features, the structuring and the penetrating lesions that can be seen in the early phases in up to 80% of the population at the time of diagnosis. This is a very surprising data, but this is, and also for establishing the diagnosis at the moment of the diagnosis, because it's key, because the location of the disease is quite stable over time. So establishing a precise map of the lesions at the moment of diagnosis can be key for following these patients. Once the diagnosis of IBD is established, there are a number of potentialities that imaging may help. is an objective confirmation of activity when the patient had a flare, because symptoms are very specific. We need an objective test for confirming the activity, for extension, for assessing the severity, for detecting the complications, and also for there are a number of evidences indicating that imaging can be useful for monitoring patients under medical treatment. As has been said, the criteria of colitis is the same as the small bowel, and there is a gaining interest in including enhancement on ultrasound, but the routine introduction of contrast-enhanced ultrasound for increasing the accuracy for detecting segments with pathology is very mild. So maybe it can have a role for grading the activity, but not for detecting segments with activity. Also, it has been commented there are a number of parameters by MR that can be described for detecting active signs of colitis. But if we are more restrictive, we are looking at what happens on the positive endoscopies, and then we move to imaging the two independent parameters, as Jepper-Stoker comment, was the wall thickness and the contrast, and increased contrast enhancement on the colon. Diffusion is gaining also interest in the workup of these patients, but it is true that diffusion may have a higher sensitivity for detecting early lesions in chronic disease, mild lesions, after lesions that usually cannot be identified by conventional MRE. However, the main limitation of diffusion is the low specificity, so it's a bit risky to take decisions based on the diffusion alone, because we are overestimating the extension or the segments with activity. So we have to be a bit cautious in taking decisions based on diffusion. By contrast, in more severe Crohn's disease and ulcerative colitis, the accuracy of diffusion is quite similar to MRE. Apart from the detection of activity, it's important to grade the severity because it has therapeutic implications, and this can be done by using the more wall thickness, the more severity, the more Doppler changes, the more severity, and the more peak, the more differences in the increase and enhancement using contrast enhanced, the more severity at ultrasound. As has been introduced before on the colon, we can use these two parameters for detecting segments with activity, and we can use these two other parameters for detecting severity. Maybe there are some others, but at the moment we know that the identification of ulcerations, that appears that these defects on the thickening colonic wall and the presence of edema on MR, we can, with a single identification of one of these two or the two, we can say that there is activity and this segment has severe lesions. For detecting these severe lesions and for assessing the activity, what is key is to avoid having collapsed segments, because we are at risk to overestimate or infraestimate the detection of activity. We know in indirect comparison of the studies evaluating the colon with and without colonic distension, in these indirect evidences, the sensitivity is somewhat higher when the colon is distended, and in the single study, still not published, that compare what happens on the segments with and without colonic distension in the same patients using ileocolonoscopy as a reference standard, we can see that when the colon is distended, we have a mild increase in the specificity, where this conclusion is based only in 12 segments with activity on the colon, so we cannot take robust evidences about this. In our institution, when we try to assess the colon, and this is one example coming from this study, the Finch study, what happens, we use the distension of the colon just to avoid having a collapsed segment, is just to put the patient on the machine connected in a flexible tube with the enema bag, and just to fill all the segments. And it's not necessary to reach a distension like enteroclysis, because the tolerance is lower and we are at risk to have some unexpected accident inside the machine. So by distending this segment that apparently has activity, so we can confirm with more confidence there is activity, and we can see these abnormalities of the mucosa. We can be more precise on assessing the activity. Then for ulcerative colitis, there is a little information of ulcerative colitis. You know, the main differential features between ulcerative colitis and Crohn's is the more continuous involvement on ulcerative colitis. affecting from the rectum to more proximal segments, and the inflammation is more superficial, and this occurs in both endoscopy. You can see ulcers on Crohn's are more deep. Here, ulcers on ulcerative colitis are more superficial, and on MR, the abnormalities in this segment with severe lesions are the wall thickness is much more discrete, much more or less evident than in Crohn's. So we have to look some other features on ulcerative colitis, for example, the enhancement, the presence of edema, or enlarged lymph nodes that is much more variable on Crohn's, it's more stable on ulcerative colitis, or some other extraenteric features like Combs sign. The main complications on ulcerative colitis is the toxic megacolon. We don't need cross-sectional for it. We can establish the diagnosis by using a plain film, and we can take use of cross-sectional, especially CT in emergency situation, for ruling out the presence of ischemia or perforation. There is a risk of 30% of perforation in that patients. Toxic megacolon can also be seen on Crohn's disease, but with much less frequency. The classical complications of Crohn's disease are these, and the number of stricturing and penetrating lesions increase over time. The pattern is exactly the same than in small bowel. I will skip all these details. Just a brief comment on the stenosis. It's important to try to assess the length of the stenosis on the colon, because it's an area where we can endoscopists can easily arrive, and in case of these obstructive lesions, that the endoscopists can only see this, but he doesn't know what happens, what there is beyond this little hole. But if the stricture is very short, and short means less than 4 centimeters, easily they can dilate this stenosis, and we can have, and this information is key for establishing the treatment. If the stenosis is longer than 4 centimeters, it's unlikely to get a successful dilatation, and then the patient may move to surgery if symptoms persist. Just some comments that the patterns of inflammation, fistula, and obstruction component may coexist, and this is one of the first examples I get from at the beginning of my experience working in the colon, but it's very representative. And we can see this is the sigmoid, an stenosis of the sigmoid with increased enhancement. This is an intramural abscess, and the inflammation on the abscess generates this stricture, and this abscess at the same time fistulizing outside with an extramural abscess, and this abscess at the same time fistulizing to the urinary bladder. So it's a very complex lesion, and the patient underwent surgery. There is a very good correlation. Fistula, as I told you, has the same appearance than in the small bowel. And lastly, just the same that Chapstoker comment, there's a freshly baked paper published in gastroenterology comparing the accuracy of MR for achieving the mucosal healing versus endoscopy in patients underwent to anti-TNF on the period of 12 weeks. After the induction period, we are able to detect changes, indicating that MR is very sensitive for detecting these changes and reliable, because at the time when the segments do not achieve mucosal healing, the inflammation, the ulcers persist, we are able to detect. The accuracy for detecting the healing of ulceration is very high, and also high for the mucosal healing. But we will discuss later tomorrow in the room A, the changes on the bowel after treatment. It's very interesting. These examples have been shown. So in summary, the diagnosis of Crohn's and ulcerative colitis relies on a combination of endoscopy, clinical symptoms, imaging, pathology, and biomarkers. In the adequate context, we can establish the diagnosis of Crohn's disease, and considering that cross-sectional has similar accuracy for extension and detecting activity and grading severity than endoscopy on the colon, we can use this technique as a first-line tool, especially considering that we are able to better assess the complications than endoscopy, and we can follow up these patients by cross-sectional. However, when the MRE or the cross-sectional are normal, that are the main limitations in early Crohn's disease, the endoscopy can be considered. And the integrative approach, that is another of the adjectives, is a bit challenging because it's quite complex in that patients. Of course, in young population, we have to choose the ultrasound MR, avoiding CT, but there are more factors, for example, the emergency situation, the availability, and the expertise that are also relevant for choosing the right test in each situation. And thank you very much.